Hello everyone, now we continue our discussion of infectious disease, the key main features. Alright, so this case is kind of interesting. So you see 28-year-old man comes in with fever, headache, myalgia. So this is so far, it's non-specific, doesn't tell us much. But if you combine that with bilateral redness of conjunctiva, okay? There is tenderness in the lumbar and paraspinal muscles bilaterally, and then you combine it plus transaminitis and thrombocytopenia. Platelet low, LFT a little bit elevated. They give you like serum markers. Creatine kinase will be high as well. So they tell you diagnosis. What is that diagnosis? This diagnosis could be leptospirosis, okay? So how does that present? Usually present like with most cases mild, self-limited, because better and so on. But sometimes when it comes bad. It comes like with fever, myalgia, arthralgia, headache, conjunctival suffocation, this is what it's called, GI symptoms, nausea, vomiting, hepatosplenomegaly, lymphadenopathy, jaundice in severe cases called Whale syndrome. And risk factors, there's somebody farmer, there's recreational, like swimming, kayaking, household pets, livestock, you know. And the greatest in the tropical areas, that's what is greatest, okay. And it's carried by the renal tubules of mammals like rodents, you know. Alright, so this case, it's interesting about the spiral. Another case, you see 65-year-old came in with fever, fatigue, body aches, and flat hemidiaphragm bilaterally, has COPD. So this fever, fatigue, body aches, you know, cough, this like when you have this symptoms may be flu, okay, and then it has past medical history of COPD, and then they tell you what is the best next step would be oseltamivir. So this patient is at risk, you know, just treat him like above 65, influenza above 65, just treat it with oseltamivir. Or if they're like, treat them the same as if they're pregnant or immunosuppressed, morbid obesity, or somewhere in nursing home. Above 65, just treat, give them, could decrease comorbidity, and they won't end up in the hospital with bad pneumonia, you know, or superimposed bacterial over viral. Alright, now we have another lady, 33-year-old, came in kind of same thing, fever, fatigue, but this one addition is scleral icterus, but hepatitis A antibody, hepatitis A virus, IgM is positive, and hepatitis B surface antibody positive, which is like being vaccinated before. So this is acute hepatitis A infection, and the plan is that what do you do? Do you vaccinate under, well, usually the options decide your management. So do you vaccinate everybody? You vaccinate just the household? So you want to do HIV, or do you give immunoglobulin to the household? That's the question. So you give hepatitis A vaccine to all household contacts. Okay. And so because they're close contact with them, okay, close contact with somebody with hepatitis A, you treat them. Same if somebody have liver disease, there is like sex with men, IV drug abuse, travel to endemic countries, you need to vaccinate them with hepatitis A. Okay, close contact with international adoptee, you know. Clothing factor deficiency, there's child care worker as well. They may benefit from vaccinations as well. Alright, now we have this patient have vaginal discharge, 2745, had vaginal discharge. Okay. What do you have? It was diagnosed with trichomonas, okay. But while you're testing, troponema pallidum immunoassay is positive. So what would you do in addition to treat trichomonas? Do you treat her or not? Yes, absolutely, you treat. Because since you don't know the duration here, you go Mercedes-Benz, penicillin, benzathine, penicillin, weekly for 3 weeks. Okay. Because you don't know latent asymptomatic, treat them same thing if they have like cardiac syphilis or gomata. If it's a neurosyphilis, then no, it's every 4 hours for 14 days. It's more intense. If just primary or secondary, just treat it with one time, one time penicillin, that's it, you'll be good to go. Okay, now another case. You have 41 or 42-year-old man came in with headache, fatigue, neck pain, sore throat, and RPR is positive. So this means even CF, but the CSF. So there is CSF is negative for VDRL, and they will tell you how to manage that. Is that syphilis or not? CSF is negative, but RPR is positive. What do you do? In this case, there's high suspicion of syphilis, right? VDRL and the CSF could be negative in the beginning, so it doesn't mean that you don't treat. So you give penicillin even after, even if you need desensitization, you give penicillin after desensitization. All right. That brings us to the discussion. There's early neurosyphilis and there is late neurosyphilis. Okay. Early neurosyphilis can cause like just meningitis, headache, confusion, fever, right? Can cause ocular, like posterior uveitis is the most common. Could cause decreased visual acuity, could cause syphilitic meningitis, or could cause meningovascular, like infectious. CNS arthritis causing ischemia or infarction can happen as well, stroke. This is early. The late neurosyphilis, called tertiary, usually generalized, could cause general paresis, cause generalized dementia as well, and can cause tapes dorsalis. It's not common, but it's pretty serious one. Posterior column dorsal root disease, papillary defect, diffuse neurologic signs, and may have normal CSF findings, right? Despite on all of that, neurological symptoms. Alright, now you have a patient, 45 man, comes in with abdominal pain, diarrhea, 10 to 12 small volume stool after cook out 2 days ago. And they tell you, okay, what's the diagnosis? What could cause this small volume stool after cooking outside? It's most likely Campylobacter jejuni. Okay. This is Campylobacter. This brings us to the food-borne disease. What disease is transmitted by food? Okay, if somebody just eat food and develop vomiting like within 4 hours after, it's most likely Staph aureus. We're going to see a question about that. Others, Bacillus cereus, norovirus as well, vomiting predominant. There is one that causes watery diarrhea, like Clostridium perfringens, E-tech, enteric virus, Cryptosporidium, Cyclospora, intestinal tapeworm, cause watery diarrhea. There are ones that cause inflammatory diarrhea. Inflammatory, like bloody diarrhea, like Salmonella, Campylobacter, Shiga toxin, Shigella, Vibrio, usually Parahemolyticus, and Yersinia as well. This is the GI manifestation of foodborne disease. There are foodborne illness that doesn't cause GI symptoms, cause like paralysis, like botulinism, paresthesia, like ciguatorotoxin, meningitis causes listeria, from listeria as well, cellulitis, sepsis from Vibrio vulnificus, hepatitis A causes jaundice, brucellosis causes fever, arthralgia, scombroid causes flushing and diarrhea, urticaria after food. Okay, another case they may bring, like 40-year-old man, recurrent cellulitis, and have like some, they say there's erythema and first toe. So now they're asking you how to prevent cellulitis in this patient. Okay, the way to prevent: treat tinea pedis. Okay, because this is like a door to the bacteria to cause cellulitis. So what are the risk factors for cellulitis? Like somebody diabetic, HIV, steroid, you know, it's suspected immunocompromised. And the way it present with eczema, there are other things like if there's a dry skin, eczema, radiation therapy, chronic wound like pressure ulcer, venous ulcer, and dermatophyte infection like tinea pedis. This is a risk factor for cellulitis. It's very common, so you got to know all the risk factors. Other things can cause post-surgical lymphedema, lymph node dissection, venous stasis, chronic one, heart failure, kidney disease, prior cellulitis or lymphatic scarring, obesity. All of these increase risk for cellulitis. And it's risky because it goes to the bone and the amputation, you know, it's not good stuff. Here you have 31-year-old came in with nausea, fatigue. So hepatitis A virus, IgG, is positive. Okay. And they're asking, and hepatitis B, viral load is 2300. So this is acute hepatitis B virus infection. So they told you, how do you treat that? This is acute, you just do supportive care. Okay, supportive care only. And you want to know, like, there are difference, like how do you differentiate acute from chronic hepatitis? You gotta know how to do. So it's easy. The acute, they will have hepatitis surface antigen, not the antibody, and hepatitis E antigen. Okay, this is acute. That's in the early phase. In the window phase, these antigen disappear and start developing the antibodies in the recovery phase. So they disappear, so you'll have S and E antibody, not antigen. Okay, that's the difference in the acute. In the chronic, usually you have the antibody, anti-HBs antibody. Okay, this is in somebody vaccinated. Okay, but if somebody have a previous infection, they will have antibody to the core as well. The vaccinated only antibody to the surface, but the one who has been infected before, they have core and HBs antibody, but they don't have antigen. If you have antigen, that's big stuff. That's mean acute or chronic. Okay, that's all that you need to know. That's the most important thing. Okay. Now, patient exposed to TB patient. Okay, but you do TB skin test. It shows 2 millimeter. What's best next step? You repeat tuberculosis skin test in 8 to 12 weeks. You don't start treatment now, you know. Just wait, see if there is an actual infection or not, because it takes time. Okay. Now another question they're asking you, okay, HIV patient CD4 is like 85. What prophylaxis? Okay, what medication to give, or what prophylaxis you wanna, what bacteria at risk for to do prophylaxis with, or microbes. Okay, you worry about toxoplasma and PCP. So these are the only one that you wanna do prophylaxis against. Okay. So Mycobacterium and Cryptococcus is no longer recommended. You don't need to do prophylaxis on them anymore. So Toxoplasma and PCP, pneumonia. How do you do? You do Bactrim. Okay. If Bactrim doesn't work, you do Dapsone plus permethamine and leucovorin. Okay. And that's kind of easy. Another thing is histoplasma you can do as well in endemic areas as well. Alright, so now this is okay, so now just to review, we talked about HIV prophylaxis, talked about repeat skin test, TB skin test, supportive care for hepatitis B, tinea pedis infection, Campylobacter, small volume stool, penicillin for neurosyphilis. So syphilis management is important for latent and for neurosyphilis. Vaccinate contact of hepatitis A, give them hepatitis A vaccine. Oseltamivir for influenza in older patient above 65. Leptospira if there is conjunctival sulfation, conjunctival erythema. Okay, along with like systemic symptoms like fever, weakness. Alright, that's the other part.